All right. All right, so this is not as much content as we just covered, so this shouldn't take too long. So health promotion and abuse. So we're going to talk about health promotion first. So health promotion is an important part of dealing with all of the children in this that we've talked about tonight and the other night. So we want to make sure when we are educating them is a part of health promotion. So we know we've talked about a lot of different topics to educate the parents about and the students, the children about. So accident prevention is a huge one, obviously. So accident prevention, and then so we know that food is important, sleep, taking good care of yourself, emotionally and physically. We see how important that is, but especially for the infant who can't do any of those things for themselves. That's extremely important, but that's just only a small part of it, especially when we talk about the infants. They need a lot more than just those, little bit of things. We have to make sure that we keep their appointments. They have to come in for their immunizations according to their immunization schedule, which I posted a link for you guys. There's also one in your book. They need to have those frequent well baby visits to make sure that they're growing like they should be and they don't have any health issues. We want to make sure that we educate them about things to look for that would represent an infection, and other times, things that they could experience that would require them to come in outside of just their well baby visit. So if they had a fever, or if they were vomiting for a prolonged period of time, or if they had, diarrhea for a prolonged period of time, or they had a change in their behavior. So we just don't always want them to just come for the well baby visits. We want them to recognize other opportunities that may require them to bring their child in if they're sick. So those routine checkups that we talked about, we can schedule them throughout. We call them routine checkups usually when they're older children. When they're smaller, before toddler, we call them well baby visits. Those well baby visits usually are 2 weeks. And then at 2 months, 4 months, 6 months, 9 months, and 12 months, when they come in for these well baby visits, we end the routine checkups, which can be just once a year if you're not getting those vaccinations. We're going to look at any vaccinations that you do need when you come in. We're going to be weighing you. We're going to be measuring your height. We're going to be measuring your head circumference. We're going to be looking at that growth chart that we talked about. To measure to make sure that they're on the path that they should be, or if they're at either end of the spectrum, either not growing enough or growing too much, that we make sure that there's no issue that's behind that happening, that it's just because of their genetics. And then, of course, obviously, every time they come in, we're doing teaching to parents and caregivers with regards to the issues that we talked about in detail with just the last slides that we talked about, according to each age group. So many of the children that come in to get vaccines, they do get a lot of different vaccines. So we vaccinate them against hepatitis B, diphtheria, tetanus, pertussis, rotavirus, hemophilia influenza type B, polio, measles, mumps, rubella, varicella, chickenpox, pneumococcal disease, and meningococcal disease. Also, they also can be immunized against hepatitis A, and the doctor's office will determine when each child will get these vaccines, but they do follow a schedule that was recommended by the American Academy of Pediatrics. They determine when the right time is, and then the pediatricians schedule accordingly according to that vaccine list. We do recommend that especially during those well baby visits, and up until, I don't know, at least maybe even into the age where they're 6 or 7 years old, getting vaccines, needles is a fearful time for children. They don't like to get needles. They can't really rationalize that it's for their own good. So it is a good thing to try and let the child sit on the parent's lap if they need to, if it helps them feel better. Sometimes when they're sitting on the lap, the parent can also help hold them down to keep them still, which kind of sounds like torture, but it's not. You just want to make sure that their arms and their legs are still wherever they're getting that vaccine so that they go in the muscle and not anywhere else. All right, so their immunization schedule. So at birth, this should come out actually. At birth, they're going to get their first dose of the hepatitis B. That's going to happen at the hospital before they come home. At 2 months, they're going to get another hepatitis B. They're going to get a diphtheria, a tetanus, a pertussis, rotavirus, Haemophilus influenza type B, polio, and the pneumococcal disease vaccine. At 4 months, they're going to get diphtheria, tetanus, pertussis, rotavirus, another Haemophilus influenza type B, polio, pneumococcal. And I did attach that link for you guys to take a look at on Brightspace. The most common side effect that we see from these side effects is typically just a low-grade fever. Sometimes you will have a child who can get a high fever, 102, 103, but that's not the norm. Typically, it is a low-grade fever. They're going to report tenderness in their arms or their legs where they got the vaccine. It is not uncommon to have swelling at that site. They kind of feel like there's like a little ball in there. Sometimes a little bit of redness. All common side effects. We usually give acetaminophen for fever. Sometimes the doctor's office will give you a sample while you're there. They'll give it to you right after they give you the immunization. Sometimes parents give it before they come in the doctor. Sometimes they give it when they go home. It just depends. Another thing that we can do for the injection site to help with that pain is they can give them cold compresses. We should understand that they may be fussy for a few days. They might want to sleep. It's very common for them to come home and not eat as much and to sleep long periods of time. So they should just be, you want to educate the parents that that is an expected finding. So we just want to make sure that we encourage them to drink fluids, even if they're not eating, and then just give them a lot of support. So hold them, cuddle them, snuggle with them, just make them feel better because they might not feel too good. And they might be a little traumatized depending on how many they had. Whoops. All right. So again, during those routine health visits, we want to make sure that we are talking about talking about their the measurements that we took that day, the head circumference, the growth, the height and the weight. After we plot them on the growth chart, we want to talk to the parents about those results. If it's normal, if it's not normal, if it's, outside of what we would expect to see, if there's any changes that we want to make, talking about things like that. We want to talk to them, make sure that they're being safe when they're bathing the child at home. So avoiding any of those bubble baths, making sure that there's a supervised adult with the child, talking about diapering, preventing diaper rash, dressing the child, and address any sleeping pattern issues, and then dental. So it's kind of like a combination of the nurse is listening to what concerns the parents have, but then after you address the parents' concerns, then you just have a list of health promotion things and education that you want to talk about as well. But we always want to listen to what the parent has to say and address their concerns. And then of course, accident prevention is definitely needed education in all those age groups. So obesity is one of the health issues that we worried about our about children developing obesity and carrying that into their adulthood. So obesity is generally defined as an excessive accumulation of fat that increases the body weight by 20% or more over that ideal weight. Overweight means that the person's weight is more than average for the height and body build that they have. So we do see that unfortunately obesity often does begin in childhood, not all the time, but often it does. We know there's a lot of different factors that contribute to it. Some of it is genetics, some of it is our social environment, our cultural environment, our body's metabolic rate, and psychological ones also can contribute to the development of obesity. Many children that don't know if they have anxiety or things like that, some people don't have an appetite, other people will eat too much. And if they're, many times we see this in children that they don't really understand that they have anxiety, they don't realize that they're struggling with some type of a mental health issue, so they will turn to food to help satisfy their emotional needs. So we call that polyphagia. So this is why we see that it manifests in children, and we notice it in childhood because they don't really know what's happening. Or it could just be that they're sedentary, their parents didn't play sports growing up. They're, today's society, a lot of kids don't want to play sports. They want to stay home. They just want to, stay home and watch TV. They want to play video games. So it's a lot of different things that contribute to the development of obesity.
Ms. Davis,
Yeah.
how does that, I guess, differentiate from binge eating, the polyphagia?
So when it's a smaller child that does it, they don't realize that they're doing it. They won't try and hide it. Mm-hmm. They'll just eat. They eat and eat and eat and eat. But as they get older, and they start to realize that it's wrong and it's an eating disorder, they'll hide it. They'll eat. They'll go up in the bathroom and vomit. So you'll see those characteristic changes as it manifests. But certainly that's where we see it, and it certainly can take that road to where it develops into an eating disorder.
Gotcha. Okay, thank you.
Yep, you're welcome. So treatment of obesity, obviously the first thing we want to do is we want to talk to the child, and we want to try and explore what their attitude is towards food. So, what are they learning at home? So tell me what your diet typically looks like, for all 3 meals. What do you usually have when you eat breakfast? Well, no one's at home in the morning. I get myself on the bus, so I take ding dongs and yoo-hoos for breakfast. So you can learn a lot by a food diary. You can have them do a food diary. You can ask them about their foods. We want to know what they think. So have they been brought up that, maybe they're on a lower income, maybe they can only afford certain foods, so that some of their choices aren't healthy. So we really just want to know what they think and what their situation is regarding food choices. We want to make sure that we don't make them feel inadequate. We still want them to feel that they're worthwhile. We said in a couple of our slides that we talked about earlier that at certain age groups, they will correlate with the way they look to their self-esteem. So we want to educate them and let them know that just because they're overweight or they're obese does not make them unacceptable, that they're not any less than anyone else. So we want to make sure that we are making them feel worthwhile. And then we want to make sure that they have the support of an adult in their life, someone that the child can gain, someone that the child respects, that they can, that they look up to, that they can give good, that role model can give them good advice and help them make the necessary changes in their life to be able to lose weight. And sometimes it's not just that there's not a person there that can do that, but maybe it's a lack of education on their part as well. I mean, I know myself, I grew up in a household where everything we ever did, we celebrated with food. Every, night when I had snack, it was cookies, Doritos, it was all these unhealthy things. And that's just how I was raised. So I really didn't know any better. And then when I got older and I was still eating gummy bears and combos every night, I had to say, I don't want to be like this. So I have to do education. So it might not just be that there's no one there willing to do it. They just might not know. So then there's an opportunity to educate the whole family, not just the child, because there is a lot that goes in with nutrition. We've talked about that before. There's a lot of components. Oops. So we know that children are not born with this great immune system. So they have to develop their immune system through actually experiencing a disease or through their vaccination for protection. So we know that the child's integumentary system is in place at birth, and it's going to continue to mature as they get older. They're going to be less susceptible to different things as they've been, as they have been exposed to certain things throughout their childhood. Their integumentary system and all the other supporting structures inside the body, nasal passages, hair, things like that, are going to protect the body from attacks from those infectious microorganisms. It's going to work to help the body get rid of the foreign materials and then resist future invasion, and it's going to build their immune system. As the child develops, the immune system matures as well, unless they have some type of a health issue which causes a problem in their immune system. Then we would have issues. So how do children develop communicable diseases? Well, they are in close quarters with each other. They hang out a lot with each other. They get very close to each other. They eat off of each other. They drink off of each other. So droplet, direct or indirect contact with some type of body fluid or discharge, contaminated blood, contaminated food or water. Many of the communicable diseases can be prevented with the immunizations and vaccines, and then using standard precautions. But it's kind of hard sometimes with kids. They just, like we talked about earlier, they go to the bathroom, they don't wash their hands, they just don't have good health habits. And really, they have to be taught them. So if they're not taught them at home, then that's going to put other children at risk when they come to school. So some of the communicable diseases that we see is one of them is hepatitis B. So this is going to be transmitted sexually or through contact with blood or body fluids. It can be transmitted to the fetus across the placenta or by contact with those vaginal secretions and blood during delivery of the fetus. All infants need 3-dose immunization series against hepatitis B. The first dose, like we said, is given at birth before they leave the hospital. They are also susceptible to diphtheria. This is transmitted from person to person. Usually we see this through respiratory droplets. So if they're coughing or they're sneezing, or they on their hands and then they touch something else, or they cough and sneeze and they contaminate the air or other things around them. Tetanus is also called lockjaw. This can be transmitted directly or indirectly from contamination of a closed wound. So they used to say if you stepped when you got on a rusty nail or you stepped on anything type of metal that could be rusty, you had to come in and get a tetanus shot. So, or lockjaw for older people in this group, you might remember the term lockjaw. Pertussis, which is also called whooping cough, can be transmitted airborne droplets or by direct contact with someone with an infected throat or any kind of discharge coming from the nasal cavity. Haemophilus influenza is transmitted via airborne droplets. Droplets also can come from discharge from the nasal cavity and the throat. You guys do need to know how these diseases are transmitted. Rubella, also known as German measles. This is transmitted by direct or indirect contact with droplets or nasopharyngeal secretions. Congenital rubella infection can result in a spontaneous abortion, a stillbirth, preterm delivery, and congenital anomalies. So this is something that's very dangerous for a pregnant woman to get. Breastfeeding, however, is not a contradiction to getting the vaccine. And the best treatment for congenital rubella infection is just to prevent it. Preventing the spread, prevent anyone from getting it. The mumps is transmission via airborne, droplet, or direct contact with saliva. The measles, transmitted with direct or indirect contact with droplets or nasal secretions. Varicella, transmitted via airborne, direct or indirect contact with saliva or uncrusted vesicles. So those vesicles, so like the chicken pox, when they scratch and they leak and there's that liquid that comes out of them, that's when they are going to be transmitted. Once they start crusting over, they're not contagious anymore. This vaccine is not appropriate for pregnant women, and the best treatment obviously is prevention, but there is a vaccine for this now. And then hepatitis A can be transmitted from person to person through the fecal oral route or consumption of contaminated food or water. So teaching good hand washing techniques. So we see a lot of this in like restaurants that have contaminated food and stuff like that. People that go to the bathroom and don't wash their hands. Erythema infectiosum, also called fifth disease. It got its name because it is the fifth of the 5 viral rashes that children can be exposed to. The other ones are measles, rubella, chickenpox, and roseola. You can get this via droplet and contact with respiratory secretions, and we don't build an immunity for this. So what would the nurse want to do when we're caring for children that may have one of these communicable diseases? We would just want to make sure that we provide any type of supportive care. So if they are hospitalized and they present with a fever, we're going to give antipyretics. If they're not eating or drinking, we're going to make sure they're having a good intake of fluids. If they're having diarrhea, again, making sure they're having good fluids, maybe electrolyte replacement. So we're just going to do that supportive care that they need. Depending on what type of disease they have and the symptoms, we might be giving them bed rest. It might not even be something we have to tell them. Usually when kids are sick, they're down for the count. So they rest until they feel better. Again, adequate nutrition and fluids. Make sure we're following those transmission precautions. If they're airborne, make sure that we're wearing the appropriate PPE when we go in. Educating the parents as well, what they should be doing to prevent spreading it from someone else. Administer any medications that are ordered, maybe IV antibiotics, antipyretics, and then of course offer comfort measures. So warm blankets, cooling blankets if they're hot, things like that. So we know that immunity can occur a couple different ways. So active, natural, and passive. So active immunity, this comes from NERN 110. We initially talked about this many, many months ago. Active immunity occurs when antibodies are formed after the child gets an immunization with a vaccine. Natural immunity will occur. It's often genetically determined, and it gives a person a resistance to a certain pathogen. Passive immunity occurs when a person has been exposed to a certain disease and is given antibodies that have been obtained from an immune person. And I would know the types of immunity for sure. As well as communicable diseases, they are also at risk for parasitic infections. So pediculosis is one of the things that especially school-age children can develop. It's head lice. We usually treat this using non-prescription over-the-counter medications. There's a bunch of different brands. There's a couple listed there that your book talked about, but there's a lot of different brands in the store. This is quite a process. After you have to go through, you have to pack up everything in the house. I mean, in their room that they've had contact with, you have to wash all their clothes. Everything has to be bagged. It has to be bagged for a certain amount of time so that the eggs, if they hatch, that they die. It's a big, long process. But to get it out of the hair, what they usually do is they thoroughly shampoo it. They dry it, and then it's combed with a special fine tooth comb that comes with the package. You dip it in warm water to remove any of the nits, and you basically go through the hair and you just keep combing it until you get all the nits out. You should be able to see them on, sometimes you have to have a magnifying glass. Sometimes you can see them on the comb. You just want to dip them in vinegar to remove what's on there and then do it again. It's a very hours. It takes hours depending on what type of hair, especially if it's a girl and they have longer hair, or a boy could have longer hair. It takes a long time. So for protection, when you're treating a child that's in the hospital, you're going to want to make sure you wear a disposable gown, gloves, and you're also going to wear a head cover because you do not want to get them because they can jump and they're very contagious. Usually they go through entire classrooms very quickly. Scabies is another one. It's a skin infestation that's treated with Parental cream or something called Lidane lotion. Also can be contagious. So you would just want to use the proper PPE, whatever the hospital has in place. All right, so we're going to finish up tonight's lecture with abuse in the family and also in the community. So when we talk about abuse with children, we can have child maltreatment, child abuse, and child neglect. So child maltreatment itself is just a very broad term. We use that to just describe all of the types of child abuse. So we talk about physical abuse, sexual abuse, emotional abuse, and then any type of acts of negligence. So acts of negligence are not always intentional, but they do fall under this umbrella term, child maltreatment. So child maltreatment is usually committed by a person that's responsible for caring for this particular child. So it could be a mom, it could be a dad, it could be a grandparent, it could be a caregiver at an orphanage if that's where the child lives. So who's ever responsible for caring for the child at that time. The term child abuse is used to describe acts of commission which result in harm or the threat of harm to a child. And then child neglect is used to describe acts of commission where there is a failure to provide for the child's needs or to protect the child from harm. So like I said, it is not always intentional, but it does fall under that child maltreatment umbrella. Whoops. So it is estimated that the amount of children that visit the emergency rooms each year for abuse is anywhere between 700,000 to 1.25 million. Although these are only the injuries, these are only the cases that are actually recorded because these are the people that actually visit the emergency room. We know that these numbers are a lot higher because children are abused every day and it's never reported and they never visit the emergency room. So we know that these numbers are a lot higher. The age group of children between birth to 4 years old has the highest number of victims of child abuse. Child maltreatment is not limited to a certain age group, although it's more, we see the highest numbers in the birth to 4 years old. It can occur at any age at all. And actually in recent years, courts have now started to view fetal exposure to drugs and alcohol abuse as actual child abuse. Not in every state, but more states are starting to recognize this. We do see in lower income families that they show a greater evidence of violence, neglect, and sexual abuse. It is known that abusive parents usually have inadequate parent skills. If they don't have proper parenting skills, they have unrealistic expectations of children. They may not respond appropriately to the child behavior. So if we go back now and we talk about revisit the fact that they said that children from birth to 4 years old have that highest number of victims of child abuse, it kind of makes sense when we think about that birth to 1 year old and then that 1 to 3 year old, how busy that toddler was, how impatient they are, how they want to do everything, how they say no, how they defy things, and then especially from birth, just how much care they depend on that loved one for. So that is why we see that in that birth to 4 years old in that category. It kind of probably makes a little bit more sense now. Not that it's acceptable, but you could see why that happens. And kids don't come with a parenting guide. So if people that are parents now haven't been raised a certain way or they weren't raised with great, parents themselves, then these things, these are cyclic events that we see that come again when they raise children. So we also know that there's different family stressors that go on in our families, and how we handle these stressors that can lead to child maltreatment, you know, having multiple children, a loss of a job, a loss of a home, a sick, you know, parent, or caring for a loved one trying to work. These are all family stressors. Poor parenting can lead to abuse. Like we said, if that parent has unrealistic expectations of the child, or if they have dysfunctional coping skills. So this certainly is not all of our responsibility, but as a nurse, we need to do our part and make sure that we're educating them when they come in about some of the things that what we would expect to see. You know, we know it's frustrating, but this is a normal thing. This isn't always going to be the way it is. There, you know, things are going to get better. So we need to educate them so they have a realistic expectation of their children. Physical punishment can be classified as abuse if it leaves a mark on the child, if it causes any type of injury, or if it threatens their physical or their emotional well-being. It's considered abuse. So what are some signals that would tell us that we might have a child that is not being treated properly, that might be being abused? So we know, we've talked about the different categories of these kids, and, you know, almost up until they're 11 or 12 years old, they're clumsy, they're falling all over themselves. They have a lot of bruises probably. If you have children, you know that sometimes you don't even want to take them to the doctor's office because you're afraid they're going to think that you've abused them, because they have bruises all over their bodies because they're constantly falling, they're hitting their head, things like that. So bruises that occur usually over those bony areas, such as their knees, their elbows, their shins, their forehead, those are typically things that we would see that could be normal just from children running around being clumsy related to their developmental stage. Bruises that occur in other areas, so soft tissue areas on the body, so on their bottom, their genitalia, their thighs, the back of the knees, the upper part of their back, the nose, their eyes. These are things that we would try and say, okay, maybe there's something else going on here. It doesn't mean that it is, it just means that probably we want to take a closer look and do a little bit more investigation. Burns, also another common type of an injury that we do see in children. So anything in that soft tissue area, again, the back of the knees, the upper back, the nose, the eyes, in their bottom, their genitalia, any of those areas should be suspect that there's something going on. Shaken baby syndrome is something that we see a lot of. Unfortunately, this occurs when a small child is shaken by the arms or their shoulders, but not just, you know, one or two times. It's in a repetitive, very violent manner. So they're really shaking and shaking and shaking for a period of time, and they're doing it very aggressively in a violent manner. What happens when this happens to the child is that it causes almost like a whiplash injury to their neck. It can also, because their brain is, you know, the brain is still a little bit more mobile in the head. There's room in there between the brain and the hard part of the skeleton of the brain of the head. There's movement in there for the brain, because we want, if there's ever any type of injury there, we want it to be able to swell and not cause any further trauma. So we want that little bit of area there where when we shake the children like that, their brain kind of like bounces off. It can hit the hard part of the head there. It can cause edema. It can cause any kind of damage to the brain stem. It can cause retinal damage. It can cause hemorrhages inside the brain. So that can cause the child to suffer a multitude of issues. They could have loss in vision. They could have a cognitive impairment and even death, sometimes coma. So it's a very serious issue. So some of the manifestations that we might see, these children may present with being very lethargic. Their parents might say that they've been sleeping all the time and they can't wake them up. They may be extremely irritable, just crying for no matter, you know, even if the parent's trying to meet all their needs, they're just not able to. They're very irritable, poor feeding. So remember, this usually happens with babies. So babies can't really say something happened to me. So the only thing they can do is be irritable and then they stop eating, they can vomit, and then of course seizures, because we have stuff that's going on with the brain. All right, another issue that we deal with is something called Munchausen syndrome. So in Munchausen syndrome by proxy, one person is going to fabricate or induce an illness in another person to get attention. So you can have Munchausen syndrome yourself. We usually see that in older adults where they believe that they have something. Munchausen syndrome by proxy, this is usually the mother who fabricates or induces an illness in another person, usually it's in their child, to get attention. So when a caregiver has it, that person, the caregiver, is what they'll see is that they will frequently bring that child to the healthcare facility, and they're going to report symptoms of illnesses, but the child is actually well. Most often it is the mom who has the syndrome, but we do see it in caregivers sometimes. The mother, and sometimes what we see is that the mother will injure the child in order to get the attention of the doctor or medical personnel in the ER at the hospital. Sometimes there have been cases reported where they slowly poison the child with a number of things. They use prescription drugs, they use alcohol, other type of drugs. They can suffocate them while they're sleeping to cause apnea, to cause some type of damage in the child. But it can be very hard to diagnose this, because as the parent keeps bringing them in, or if it's a very serious situation and they bring them into the emergency room, the mother is very, very attentive to the child. So it's kind of hard for you to suspect that this is going on. They often have a good medical terminology vocabulary, but again, it's very often it's hard to prove it. And because the parents are so involved or the caregivers are so involved and attentive with the child, you don't really want to believe that that's what's happening. It's usually after these frequent visits to the hospital, frequent visits to the doctor's office, and they can't find anything wrong with the child, is that when they start to suspect this. So emotional abuse is something else that we can see that children suffer from. So emotional abuse can be just as serious, and it lasts way longer than what we see from physical abuse. Bruises, broken bones, things like that heal, they go away. Emotional abuse does not. But it's also much more difficult to identify. So there's a couple different types of emotional abuse. So there's verbal abuse. So things like humiliating the child, scapegoating, having unrealistic expectations and belittling them, erratic discipline. Those are forms of verbal abuse. There's emotional unavailability when whoever the caregiver is, they become more absorbed in their own problems and they don't have time for their children. They don't listen to their children. There's insufficient or poor nurturing, or threaten to leaving the child or otherwise end the relationship. So I've seen it before where I've seen parents that say, I've even seen a woman go as far as to get in her car. The kid wouldn't get in the car. He didn't want to leave. He wanted to get the toy that he wanted. And the mom was like, if you don't get in the car, I'm leaving you. Well, we know, based upon the different things we talked about tonight, that at that age, they need their mom, or their dad, that's their whole world, their caregiver. So threatening them obviously is going to cause some type of emotional trauma. And like I said, the one time I actually saw the woman get in her car and she drove around the parking lot and the poor kid was screaming bloody murder till she came back around. So obviously that's going to cause emotional issues. Role reversal. We see this when the child has to take on the role of parenting the parent and is blamed for the parent's problems. So children, how they show evidence that they've been abused emotionally is that it presents in fear, and it also presents in anxiety. Sometimes they will also just have very vague complaints like, I have a stomach ache all the time, or it's the school-age child who spends a lot of time in the bathroom because they have diarrhea, their stomach's upset all the time. So this is how we see emotional abuse manifest sometimes in young children. As children start to get older, we may see emotional abuse as in a correlation with their grades. So performing poorly in school, not showing up, not going to school, their attendance there's attendance issues, having poor self-esteem, poor peer relations, not making friends easily is also a sign of emotional abuse. So child neglect, we did say earlier on that this is not always intentional, but child neglect is a failure to provide adequate hygiene, adequate health care, adequate education, nutrition, love, nurturing, and supervision. So all of those things that we just talked about, we know that children need in order to grow and develop as they should. So if we don't provide those things, it's considered child neglect. Often we will see that a child that presents with failure to thrive is neglected. So they're underfed, they're deprived of love, or they could be constantly criticized at home. Signs of neglect, there's a lot of different ones. Some of the ones that you may see, they may come in, they may look very disheveled every day. They may look dirty. Their clothes may not fit. Their clothes may not be clean. They might be left at home by themselves, or they're left at home to care for other younger children, their other siblings. Sometimes you might see that they eat more. They just want to eat because they're afraid that they are not going to get anything later when they get home, or they will eat and then save food to take home for later because they know that they're not going to have another meal, when they get home and when they're hungry again. Sexual abuse also is a form of abuse. It can come at couple different ways. We can see it as incest. We can see it just through sexual contact or sexual assault. All three of those occur. It doesn't discriminate. It's in all socioeconomic, racial, religious, and ethnic groups. Usually, statistics show that the abuser is often a trusted male adult. And incest, which is defined as sexually arousing physical contact between family members that are not married to each other, is common in sexual abuse cases. We see that all the time. Usually when the child is sexually assaulted by a stranger, the family caregiver usually becomes aware of the incident. They're infuriated, obviously, and upset. They report it immediately. They take the child to the doctors to have a physical examination. But however, when it's in the case of incest, like we said, where it involves the family, we don't see that. So we don't see that the caregivers become aware. The children does not always tell the parent what's happening. Usually that family member that's committing the act is able to have some type of a control over that child. They intimidate them. They make threats. If you tell your mom or your dad or your grandmother, whoever your care provider is, that I did this to you, I'll kill them or I'll hurt them. So they're scared. They can also appeal to, we said that during certain ages that children want to be loved and they want to please people. So this person may be able to appeal to that side of them and convince them that it's just beneficial and important to keep a secret. So that's important to understand as the pediatric nurse. We do see that contributing factors to sexual abuse are substance abuse, job loss, and poverty. Sexual abuse by a person, studies have shown that sexual abuse by a person that a child trusts seems to be the most damaging type of sexual abuse. So the nursing process for a child who is abused. So our goal for providing care for these patients is to focus on any injuries that they have at that present time. But it's also important that we want to make them feel comfortable. We want to make them know that they can talk to us. We want to use that open communication, listen to them, build that rapport, make them feel like they can trust us so they can talk to us and confide in us, but we also want to relieve their anxiety and the fear that they have. We want to provide nursing care that promotes parenting skills and coping skills that benefit the child as well. So these parents need a lot of education as well. If something has happened to their child, They need that open communication. They need to build that rapport with them. They need to feel like they can talk to you. If they've done something, if they themselves have abused the child, then we want to promote positive parenting skills. They might even have to take a parenting class or something like that. So they need a lot of resources, especially if they're the ones who have caused the child harm. And like it says here, make sure that you have a non-judgmental attitude. So we talk all the time about evaluating us as nurses, and we know what we can do and what we can't do. So not everybody is cut out to do this type of work. This is very, very hard. It's hard to not take this home with you. And it would be very hard for me not to have a non-judgmental attitude. So I know that this is probably not something that a field that I could work in. So definitely taking a look at yourself as the nurse, knowing what your biases are, what your, your judgmental issues are with regards to these different factors. And maybe it's not a job for you, or maybe it is a perfect fit. Maybe you would be perfect for this job. Just make sure that you're calm, you're reassuring with the child and the parent, especially if the parent is not the one who has caused the type of abuse to the child. And then try not, when you're talking to the patients, to the children, to the parents, just let them lead the conversation. Just be present with them and listen. Don't try and rush them, especially if it's a child, because it can be hard for them to talk about, and they don't always know how to find the words to describe what happened, especially if they're smaller. So in cases of domestic violence, the child may have heard, seen, or witnessed some type of evidence in the family. So it might not be any type of violence that's happened to them, but it could be from caregiver to caregiver, mom and dad, brothers and sisters, who knows? We do know that millions of children every year are exposed to domestic violence. It is a serious concern. We see it in all families of all races, all socioeconomic origins, all ethnic, educational backgrounds. It definitely does not discriminate. Usually it is where a person in the family uses some type of power or control over another person. It can be another family member, it can be another person's partner, it just depends, but whoever that person is, they're using that power and control over another person. There can be physical violence, threats, emotional abuse, harassment, stalking, are also forms of violence that are often seen. Sometimes, depending on what's going on, you have to get peace orders to keep, or ex parte orders, depending on what the situation is, to protect the child from these people in the family, or it could not even just be a family member, it could just be someone on the outside. So you have to do what you have to do to protect the child. Let's see. Even if all the family members are not victims, we have to know that each family is going to be affected by this some way, shape, or form. They don't necessarily have to see it. They can hear it. They can hear other family members talk about it. They can overhear other, parents and people talking about it from another room. They may see bruises. They may see cuts. They may see broken bones. These are things that children will know are not normal. So just because they don't actually see the act doesn't mean that they're not being impacted by it. So that is something to keep in mind. Children who have been subjected to domestic violence, they might not just come out and say, I saw this, I have this. It can be anxiety. It could be diarrhea, an inability to sleep. Bedwetting might be something that we see that they start. It was something that they didn't do before, but now they started doing it all of a sudden. They could act out with temper tantrums. They could be more withdrawn, more quiet. They don't want to talk like they usually do. And because they don't know how to rationalize domestic violence, or they don't know who to blame, sometimes they blame themselves, so they have feelings of guilt. We know that these feelings, these symptoms that they're seeing are related to post-traumatic stress disorder. We've talked about PTSD before. All those things we just talked about are symptoms of post-traumatic stress. he or she may be having academic problems in school. We might notice that they're skipping classes, they're not showing up to school. Again, behavior issues, isolating themselves from others, their friends. Maybe they used to like to play a certain sport before, but now they're not playing that sport anymore. They're not hanging out with their normal friends. They're isolating themselves. And then we know that the older child may choose or turn to drugs or alcohol, committing crimes, or even attempting to commit suicide. These are all the effects of domestic violence. Bullying. So bullying, we know, can occur anywhere in any age group. When we talk about this age group with children, it's also, you will hear some people refer to it as peer abuse. That seems to be the new name. Your book refers to it as peer abuse. I've heard it in a couple different other settings referred to as peer abuse, but it is a deliberate behavior. It's a behavior that's repeated, and it's a very aggressive behavior towards a person who is usually physically weaker, shyer, or not able to defend themselves against from the abuse that this person will give. It can be physical abuse. It could be hitting, kicking, taking their belongings, stealing their money. It can be verbal abuse, so teasing them, name calling them, making fun of them, making insults. And it can be psychological, so spreading rumors, excluding people. And then it can also be cyber abuse too, so text messaging, emailing, social networking. These are all behaviors. Today, kids have a lot of more avenues where they can bully people, and there's no accountability. Not like it was years and years ago, where the only way you could abuse someone was to actually say something to another person. Today, kids have a lot of other avenues where children can be mean and abuse them, and there's no accountability there. Usually the victim is perceived somehow as being different from the person who's abusing them. And because they're different, it's assumed that they are weaker. Symptoms may be physical, or they can be, like we said earlier, a little less obvious. So anxiety can present with a loss of appetite, diarrhea in some kids. You might see a change in their mood. Again, a change in their academic behavior. So they might not be performing as well as they used to, or they will avoid certain situations. They're not going to put themselves in situations that will make them vulnerable. Support from trusted adults is very important. Listening to your child, asking questions, listen to what they have to say, help develop their self-confidence. By developing their self-confidence, we can help them to be able to have them good coping mechanisms that will help them in bullying type situations. Parental substance abuse is another issue. It is estimated that at least 10% of children come from a home affected by alcoholism of one or both parents. Substance abuse is not just a problem for the caregiver or the parent. It's a family problem. It affects the entire family. If one member of the family abuses any type of alcohol or any type of drug, then that whole family unit is going to be infected in some way, shape, or form. It can cause a lot of different adverse childhood experiences. It can cause physical abuse, emotional abuse, sexual abuse, and then it can have an influence on whether or not they grow up to be addicted to drugs and alcohol as well. Children of substance abusing parents often become isolated. They become what they call loners. They avoid relationships with others because they fear that the substance abusing parent might embarrass them. They may say something that's inappropriate in front of their peers, so they choose not to bring those people home. They'll hang out with them at their house, but they won't bring them to their house, or they will avoid it altogether because they're worried. As parents get further into their substance abuse and that condition starts to worsen, obviously that's going to be a correlation with an increase in the family's dysfunction and increase in social isolation as well. Codependent parent directly or indirectly supports the addictive behavior of the other parent. So it's very hard to deal with someone who has an addiction, whether it's a parent to a child that has an addiction, or a husband to a wife, or a wife to a wife, a husband to a husband, whatever that unit looks like in that house. It's very easy to be codependent and not even realize that you're doing it, because when it affects your loved one, you want the best for them and you love them and you're willing to overlook certain things. You want to keep your family unit together. You don't want to leave the mother of your child, the father of your child, whoever. You don't want to break up that family unit. You don't realize the effect that it's actually having on the family. So it is very common that we see that codependent person will make excuses for the addict's behaviors. They will make excuses for their actions. They want to preserve the opinion that their children has of that other parent. So they don't want to always tell them exactly what's happening. They want that child to love that parent and they protect that parent. It is a codependent behavior. They will overlook the parent's moodiness, their erratic behavior. They overlook a lot of things. Children who live in families that are subjected to substance abuse can, they can react in a variety of different ways. Some of them, like we said, will have anxiety. Some of them, if they're young enough and they don't understand, they're just confused. Some are angry, maybe because they remember their parent a certain way before things changed, and now they don't like who their parent is now, and they're angry that things have changed, or maybe their mom or dad or whoever the caregiver is not in their family unit anymore. Maybe they've gone to prison. Maybe they had an overdose and they're not alive anymore. So that can cause anger. Anger can lead to depression. It can lead to guilt. A lot of displaced guilt, not knowing exactly if they did something to contribute to that behavior. And then it can also lead to addictive behavior somewhere down the line. These children can become overachievers in school, but they do seem to be isolated emotionally. And as these children become adolescents and they become young adults themselves, it's very possible for them to have issues, like we said, with substance abuse or even eating disorders because of all those issues, the confusion, the anger, the guilt, the anxiety. And I did not turn the slide, did I? Or I just have 2 slides. No, I didn't turn the slide, sorry. That's only twice tonight I did that. I'm doing pretty good. So behaviors that we as nurses should be alert for, as well as other healthcare personnel that can show that maybe there's an addiction problem in the family. So we're looking for the child that loner child who avoids interaction with classmates. It could be that they used to enjoy being, the parent might say that they always used to do X, Y, and Z, but now all of a sudden they don't, or the caregiver could report that. We're looking for the child who is failing in school or has a lot of unexcused absences or truancy. Any child that's had a complete change in behavior. So this is the straight A student who went to school all the time, now is barely passing any classes and they're having truancy issues. This is a sign. These are red flags. Children with frequent minor physical complaints, those headaches, those stomach ache, diarrhea, things like that can be caused by anxiety. Children who steal or commit acts of violence, children who are aggressive, and then of course, children who abuse drugs and alcohol. And that is it. So remember, this is going to be on exam 3. The exam 2 material ended with growth and development.
Ms. Davis, is there going to be a review or like a exam review coming out? Okay.
No,
checking.
not for exam 2. Nope. And probably not for exam 3 because Mrs. Tizo will be teaching all of the material for exam 3 and 4, except for what I taught tonight. Okay, so you are so far supposed to do your predictor tomorrow at 6, but I'm thinking there is a small possibility that I may be able to move it to Tuesday. because originally your Hearst review was supposed to be on Tuesday, but they switched the dates. So we kept open Tuesday, Wednesday, and Thursday, but your classes are Wednesday, Thursday, and Friday of next week. So you should have had lecture on Thursdays. So I just have to check one other thing, but would you guys rather have it on that Tuesday if we can do it so that you have more time to study?
Yes, please.
Yes.
Okay, I do have to check. I have to check two other things actually first before I can say that. So right now it is tomorrow at 6, but I will try and check those other two things and see if we can do it. And then I will post an announcement tomorrow. But if we, either way, however we do it, it's not going to be in person. It's going to be online with me and I'll be proctoring it.
Okay, thank you.
You're welcome. So let's see, Thursday is your test, 6 o'clock at the college. That will be in person. You have your Hearst all the following week, Wednesday, Thursday, and Friday. I will give you, I got a box of books. Some books came to the college. I believe it's your Hearst books. I have to look. So if it is your Hearst books, I will give them to you. Has anybody been getting their books to home? Some people have.
I gave them my address, but I haven't received mine yet.
How long ago did you order it?
I think towards the end of last week, so Thursday or Friday, maybe.
It took a little while for it to come, so.
Okay, gotcha.
Okay. Well, I have a huge box of books that I didn't get to open today, and I didn't know what they were, and I thought it said Hearst. So I'll look. If it's yours, I will give them to you on Thursday, the ones that I have when you come for your exam.
So I have a question about that. Is it only just like the answer booklet without any other things in it? Like it's no, like it has just the questions, not the answers.
I have no idea. I've never seen this book. This is the first time I've done it with you, and I don't have a copy of the book. So I can't say, and I'm not directly involved in this. This is run by them. So unfortunately, I don't have the answer to that. Can anybody else that has gotten a book answer that question?
I don't think it has the answers in it.
I'm
looking now.
It doesn't. I think it's a workbook. Mrs. Kemsky was telling us at clinical, they're very detailed with how they do things, and that it's like a workbook. So I'm assuming there's 3 days that we'll be going through, she said everything is broken down section by section. She said they're very thorough with the way they do things. So, and it's all day long. So I'm sure we're going to get through that book in 3 days.
Okay.
Yeah. And I do know that I have heard them say that you are doing work in the workbook. You're talking about things, you're writing things down. So, but this is the first time I've worked with her. So I just don't know it. And I don't have that book. So. Any other questions? Somebody did send me, Caitlin, I think it was you, sent me an email asking about the time change, because I think it says Central Time.
Yeah, it says 10 to 4:30 Central Time. So I didn't know we were starting an hour later.
Yeah, so I did send the girl an email from that. I don't think that you are, but I need to clarify that because we certainly are not Central Time. So just look for an email from me before next week. As soon as she responds to me, I'll post an announcement letting you guys know if the time changes or anything. Okay. Any questions? So next week you will not have lecture. Tuesday, keep that on the books for right now in case anything changes. You should still, until I say otherwise, prepare for that time from 6 to 9 because anything can come up, or 6 to 10. I will let you know the next week you do have class on the 23rd. That will start your lectures with Miss Tizo. So she doesn't have anything posted right now. I don't have her lectures. She wants to post them on Brightspace. So I will work with her and make sure that she knows how to post them, and then you guys will meet with her. She will be doing in person. And then you guys are almost done.
6 more Mondays, guys. 6 more Mondays.
Yep, it'll be here before you know it. Any questions?
No, thank you in advance for changing it to next Tuesday. We all appreciate it. I know it's not set in stone, but I'm speaking that into existence. So thank
Right.
you.
Yes, I mean, I don't have a problem with it. It makes sense. It's just that we have to, this proctor test has to happen before you take your final, and then you have to take another one. And then with trying to squeeze Hearst in there, there's just a lot for us to cram in the very little bit of time that we can have you guys. So, but because of the way Hearst fell, it does look like that Tuesday will be available. So fingers crossed.
Okay, one more question. Does the group projects, there's 2 groups with the same subject. Was that a misprint?
Yes.
Or was that?
Yep. So, oh, wait a minute. I cannot minimize. Hold on. Let me move this screen. Let me go in and look. Let's see. Sorry, I'm just waiting for my stuff. Oh, yes. Childhood obesity and childhood obesity. I apologize. So Michelle's group, why don't you guys do
I think it's like smoking and drug abuse or something that wasn't there.
yeah, let's do, is drug abuse, hold on a minute. I'm trying to pull up 2 things at the same time. Drug abuse is not on there. So let's do that one because that's a very prominent issue. Let's do Michelle, Kathy, Chanel, and Ashley Wilkinson. You guys can do drug abuse. Is that okay? Have you guys started?
I haven't started yet.
Kathy,
Can you hear me?
have you started your project yet?
No.
Is there a
Chanel?
rubric for that posted?
Yes.
Okay, I didn't see it, so I'll go back and look again.
Chanel, did you start yet? No, Chanel. Ashley Wilkinson, did you start?
No.
Okay, good. So then you guys will do drug abuse. Sorry about that. I can upload the right copy.
Yeah.
Sure. The rubric and the peer review should be on page 3 and 4 of the project assignment. They're all on one attachment.
Okay, I'll go back and look. And I know this is not Thursday's class, but we don't meet for that class. ATI practice, that's due by the 14th, correct?
Yes, 11/14, your practice assessment, and the assessment has been opened.
When should we give you the templates?
It says that they're due on 11/18. 11/18, you will not be in class.
We'll be in
So
person.
So you can hand them in on the 23rd. You can give them to Miss Tizo and she'll put them in my mailbox.
Okay, so I don't know if I'm the only one, but the Hearst review, is it in person or is it online? Because it seemed like it was like confusing.
It's
Okay.
online.
Okay.
So you said the 23rd, right? For the templates, please.
Yes. No, Tuesday, November 23rd. Yep, just give them to Miss Tizo. And the assessment A has already been opened, so. And then your Yeah, so you will have lecture material for Thursday, legal and ethical issues. I will record that and post it for you so you can leave after the exam. And then you guys can email me with any issues, or I can do a Zoom and meet to see if you have any questions. All right, anybody have any questions? No, no questions. All right, I will.